Welcome back to Uncovering Bailey in Love with Snazzy Surgeon. Today, we're going to really get into disorders of the nipple.
Yeah, it sounds kind of niche, doesn't it?
It might seem that way at first glance, but you know as well as I do, for us surgeons, this little area can actually present some pretty big clinical challenges.
Oh, absolutely. And the implications can be huge.
Exactly. So today we're going to extract the need-to-know info across a whole spectrum of nipple conditions. We'll be covering everything from those developmental variations that can sometimes throw you off
Right, those curveballs you see in clinic.
to the real red flags that could signal something way more serious, like malignancy lurking beneath the surface.
The goal here is to make sure you walk away feeling confident and well-equipped to handle whatever nipple-related presentation comes your way.
I like it. So where do you want to start?
Well, why don't we kick things off with nipple inversion? I think it's a great place to start because whenever you're dealing with a patient with nipple inversion, it all comes back to the developmental timeline.
You're talking embryology, puberty, that whole process.
Exactly. At birth, everyone's mammary glands are essentially the same. But then, as our female patients hit puberty, usually around 11 or 12 years old, you start to see breast development kicking in. That's the LARSH, right?
Right, and the OSH typically happens about a year before they actually start their periods, Minar.
Exactly. You get that initial breast mound forming. And then, between 14 and 16 years old, the major milk ducts start to elongate. That's really the key step that makes the nipple protrude.
It's like they're reaching out.
Huh. In a way, yeah. But so when you see a patient with an inverted nipple, a lot of times it boils down to those ducts not elongating properly during that critical period.
Fascinating. So for us, clinically, what are the main things to consider with these patients?
Well, breastfeeding can definitely be a challenge for them. And then there's the increased risk of infections.
Makes sense. Debris can get trapped in there pretty easily, I imagine.
It sure can. It creates a perfect little breeding ground for bacteria. But one thing that's super important is to reassure these patients that developmental nipple inversion in itself doesn't increase their risk of breast cancer.
Yeah, that's a good point to address because I'm sure that worry crosses their mind.
It does for a lot of them. Okay, now let's switch gears a bit and talk about nipple retraction.
Nipple retraction, this is different from inversion.
Totally different. Nipple retraction is an acquired thing,
Yeah.
usually caused by fibrosis developing around the major milk ducts. And the key for you as a surgeon is to figure out if it's a recent development or if it's been there a while.
Ah, so the timeline matters.
Absolutely. If you see a new onset of nipple retraction, that's a red flag. And it could be a sign of something more serious going on underneath.
Like what?
Well, in some cases, it can be a sign of an underlying carcinoma.
Oh, wow.
But don't panic. It's not the most common cause, thankfully. Long-standing retraction is much more likely to be benign. Things like periductal mastitis, that's a common culprit.
So how do we tell the difference clinically? Is there anything specific to look for?
Definitely. The appearance of the retraction can give you a lot of clues. That classic transverse slit-like retraction, almost like a fish mouth?
Yeah, I've seen that.
That's pretty characteristic of periductal mastitis.
Yeah.
On the other hand, if you see a circumferential retraction, where the whole nipple is pulled inward evenly, well, that bumps up your suspicion for a possible carcinoma.
Interesting. So the pattern of retraction matters.
It's a huge clue. Now, whether it's inversion or retraction, either one can make breastfeeding difficult.
Right, and both can increase the risk of infection because of trapped secretions.
Precisely. So what do you do about it? Let's start with minor developmental inversion. Sometimes just some gentle, regular pulling on the nipple can actually make a difference.
Really, just manually stretching it out.
Yep. You'd be surprised how effective it can be. But for those more stubborn cases where it's not budging, surgery is an option.
I was going to ask about that.
But the big thing is, you got to lay it all out for your patients, make sure they understand the risks. You could accidentally cut some milk ducts during the procedure.
Yeah, that wouldn't be good.
Not ideal. Could affect their ability to breastfeed later on. And there's also a chance of changes in nipple sensation. Could be temporary, could be permanent.
It's a trade-off.
It is.
Oh.
Now, before we jump to surgery, don't forget about those non-surgical options. Mechanical suction devices, those can work wonders for some patients.
Oh, yeah. Those little things, they help gradually avert the nipple.
Right. It's a slower process, but way less invasive. Okay, shifting gears again. Let's talk about something you'll see all the time in your practice, especially after your patients have babies. Cracked nipples.
Oh, cracked nipples. Poor moms.
I know. It affects something like 10% of women who are breastfeeding. And most of the time, it's just the sheer force of the baby sucking that causes it.
Makes sense. I imagine that creates a lot of friction.
It does. And it usually starts with a small blister forming on the nipple, which then pops and turns into a little ulcer. Painful little things.
Ouch.
And here's where things get tricky for us surgeons. If those cracks get infected, it can turn into mastitis.
Lactational mastitis. Yeah, I've treated my fair share of those. Not fun for anyone involved.
Not at all. So when you've got a patient with cracked nipples, the name of the game is healing. Rest is essential. We tell our patients to rest the affected nipple for at least 48 hours if they can.
But they still need to empty the breast, right? To prevent engorgement.
Absolutely. But gently.
Mm-hmm.
Using a breast pump is usually the best bet to avoid further traumatizing the nipple.
Makes sense. And what about cleaning?
Warm water and some mild moisturizing soap. That's all you need.
Okay.
And then, to fight off infection and promote healing, topical treatments are your friend.
Antimicrobial creams.
Exactly. Mupirocin is a good go-to. Okay, now let's touch on something you might see a little less often, but still important to recognize. Papilloma of the nipple.
Papilloma? What's the deal with those?
Well, under the microscope, they look a lot like those regular skin papillomas you see everywhere else. Benign little things.
So what do we do about them?
If you catch one, usually a simple excision is all you need. Just take a little disc of skin around it to make sure you get it all. But for those tiny ones, the ones on a little stalk, you can sometimes get away with something even easier.
Let me guess, you just tie it off.
Bingo. You put a tight little ligature around the base, cuts off the blood supply, and the papilloma just shrivels up and falls off on its own.
Nice. Efficient. Okay, moving on. What about those retention cysts that can pop up around the areola? I think they're called cysts of the glands of Montgomery, right?
You got it. Those Montgomery glands are basically sebaceous glands, just like the ones we have on our face and back.
And they make sebum, that oily stuff that keeps the skin lubricated.
Yep. But sometimes the duct of a Montgomery gland gets clogged up and the sebum has nowhere to go. That's when you get a cyst.
So they're like little pimples on the areola.
Pretty much. Most of the time, they're small and painless. You might not even notice them. But if one of those cysts gets infected, that's a different story.
That's when they become a problem.
Exactly. They get all red, swollen, and painful.
Yeah.
And sometimes the only way to fix it is to drain it surgically.
Yikes. Okay, let's talk about eczema now. Eczema of the nipple and areola. That can be tricky, can't it?
Yeah, it can. But true eczema in that area is actually pretty rare. When you do see it, it's often on both sides. And usually the patient has a history of eczema elsewhere too.
So it's not usually an isolated thing?
Right. Now for treatment, we usually start with topical steroids like betamethasone cream and tell your patients to use a gentle soap, something that won't irritate the skin further.
But here's the thing, right? If it doesn't clear up with that basic treatment, we have to think about something else, something more serious.
100%. If it's not responding to the usual stuff, you got to have Paget's disease on your radar.
Paget's disease, that's a scary one.
It is. So in those cases where things just aren't getting better, you need to do a biopsy. It's the only way to rule out Paget's.
All right, let's dive into Paget's disease then. What exactly is it?
So Paget's disease is a type of ductal carcinoma in situ, or DCIS for short. It's where cancer cells start growing in the milk ducts of the breast.
And what makes it different from regular DCIS?
Well, with Paget's, those cancer cells actually travel up the ducts and invade the skin of the nipple.
So it's like DCIS that's decided to make a break for it.
Huh. Yeah, you could say that. And what's tricky is it can look like eczema at first. You know, it starts a little erosion on the nipple, maybe some itching or burning.
I can see how that would be misleading.
It is. But as it progresses, it starts to eat away at the nipple, and it can spread out onto the areola.
And here's the big concern, right? It's not always just contained to the nipple.
You're right. Sometimes Paget's can be a sign of invasive breast cancer deeper in the breast tissue, and it can spread to the lymph nodes under the arm, too.
So we're talking about potential metastasis. This is serious stuff.
It is. That's why we can't mess around with this. We need to be thorough.
So what's the diagnostic workup for Paget's?
It's the same triple assessment we use for any suspicious breast lump. You start with a good clinical exam, then you get imaging.
Mammogram and ultrasound, usually.
Yep. But the most important piece is the biopsy. We need to look at those cells under a microscope to be absolutely sure.
So once we have the diagnosis, how do we treat it?
Well, that depends. If it's just Paget's, no signs of invasive cancer anywhere else, we usually do central core excision.
What's involved in that?
Basically, we remove the entire nipple and areola, plus a cone-shaped chunk of breast tissue going all the way down to the chest muscle.
That's pretty extensive.
It is. And after surgery, they'll usually get radiation therapy to zap any stray cancer cells that might be lurking.
But what if there is invasive cancer?
Then we're talking mastectomy. We have to take the whole breast. And we'll also need to check the lymph nodes under the arm to see if it's spread.
So the treatment gets a lot more aggressive?
It does. But that's the reality of it. We have to be proactive.
Absolutely. So as you can see, even though the nipple is a small area, it can present us with a whole range of challenges, from the relatively benign to the potentially life-threatening.
That's for sure. And as surgeons, we need to be able to recognize the subtle differences between these conditions. It's what allows us to make the right decisions for our patients.
Couldn't agree more. Well, this has been a fascinating deep dive. Thanks for sharing your expertise.
Anytime. It's been a pleasure.
And to all our listeners, thanks for tuning in to Uncovering Bailey and Love. We'll catch you on the next episode.